Okay. Good morning, everyone. Welcome to the Part 3 Summit. And so this is our last class related to the domains related to the Part 3 exam. So yeah, we'll get started. Okay. So, as we all know, there are 5 domains. It's information gathering, patient safety, applied clinical knowledge, and communication with colleagues. We have completed. So, our last domain is communication with patients and relatives, and we'll be discussing about that now. And so since this is a communication exam, so this is a very, very important domain that we need to master, at least try to come to the level of perfection, because this task, that is this skill, it comes only with practice, with continuous practice. So what we will be discussing about in today's session, this is the overview. So we'll be discussing about what are the different communication types of communication that is assessed in this exam. Then what are the various strategies we can use for different types of tasks. And we'll be discussing communication with patient, communication with relatives, and how to break the bad news, consent and mental capacity, how it has to be taken, how we need to take the consent, and how to assess the mental capacity. And then we'll be having some types of communication stations. That is the kind of task that will be covered in the the exam. And we'll have some 7 scenarios, there will be a brief history and how to go about this station. It won't be a detailed task discussion, just the important points that needs to be present in each of these different scenarios. So we have 7 scenarios, and at the end we'll have some quick tips of how to go about practically, what are the pitfalls to avoid, and a quick checklist as well. So now we can see that there is a difference between sympathy and empathy. So this is a very important part, because most of the patients, that is most of the tasks, will cover something, some kind of a difficulty that the patient will be having. Either the patient will be in pain, or the patient may have a miscarriage, or there is some complication during the pregnancy, there is an IUGR or something. So in that cases, we need to address the patient, because this exam, it is a patient-centered exam, and we need to cover both their social and their emotional aspects as well, in addition to the clinical aspects. So what is the difference between this sympathy and empathy? So in sympathy, when the person is feeling bad, then we when we go and tell them, I'm so sorry that you're going through this, that becomes sympathy. But what is empathy? In empathy, you go to the patient, that is, you go to that person, you put yourself in their shoes, and then feel what they feel. That is called empathy. So you will be like, you have to go down to the patient, and you must tell them, like, for example, patient had a miscarriage, then just telling, I'm so sorry that you had a miscarriage, is sympathy. But for an empathy, then you'll have to be like, I can only imagine what you're going through. It must be really difficult for you. In that way, we mean that we are also feeling what the patient is feeling about. That is called empathy. So we should not just stop with that. At that point, I know what you like. I can feel what you're feeling. You should not stop there. You should go to support the patient. You can tell them, we are all here to support you. You are not alone. We'll be going through this together. In that way, you are giving both emotional support to the patient, and also you are making sure that you are ticking the important points related to communication in your task. So we'll have to display empathy. There are a lot of tasks where you need to display empathy. So it is an important skill to be learned from. And the next one is, you can see that here it's completely coiled, and slowly we are removing the coils, and it becomes a straight line. So what do you think this means? What this means is that you need to break down complex information. Okay, so what this breaking down of complex information is. Okay, so for example, okay, a patient, she is an Paris, and she's around 35 or 38 years old, and she's been diagnosed with a cervical cancer. Just imagine what the patient would be going through. She would be planning, like, in the next month we'll be planning for a pregnancy, but unfortunately she has been diagnosed with a cervical cancer. She'll be having a lot of doubts inside her. What about my family? What about my kids? Then how about the cervical cancer? I'm going to die. What is the stage? What are the treatments? All this will be there. So in that time, what we'll have to do, we'll have to step in and we'll have to clear all their doubts. You can do it one by one. First, you'll have to give them a reassurance that we are here, we'll be taking you through this. And if pregnancy and having kids is her main, her concern, then you'll have to address that first. There are many options after this cancer has been treated. That is, if it is an early stage, then you can give her some amount of, you know, encouragement, and tell her that once this is treated, then there are other options as well. And there are also, if nothing else can be done, we can go for donor and surrogate as well. In that way, the patient will find out, will see a light during in her path. So that concern will be cleared for her. Then you can go for the next treatment that is related to her cancer, and you can tell them one by one to the patient. And gather history sensitively. When there are sensitive histories included, then you have to gather the history very sensitively. What are the sensitive histories? This could be like the patient is going through stress incontinence, or painful intercourse, or it is some domestic violence, sexual abuse. These are all tasks where we need to take history very sensitively. And another important point is shared decision making. So what is the shared decision making? Always what we have to do is we need to give the patients the options and give them the pros and cons, and also take what are their concerns, what are their preferences. And also they may have some values, some cultural, religious preferences as well. All this has to be put into one into to put together, and then we have to discuss the options, and always give the patient the chance to decide. Even if the patient asks you, what do you say, doctor? What do you think is best for me? We should tell them that you know what is best for you. My job is to give you the options, and help you take you through this and take the decision. So involve the patient in shared decision making. So now the domains that are assessed in this exam. We'll have communication with patient, communication with relatives, and the communication with colleagues. Communication with colleagues, Dr. Meera has extensively covered in the previous session on applied clinical knowledge and communication with colleagues. So we'll be discussing about these two. So what are the tasks that are assessed? What are the communication skills that are assessed? So we have already seen breaking bad news, consent taking, counseling, that is negotiation, and explanation of the diagnosis or the treatment. When it comes to relatives, it would be mostly some distress news or some loss, or the relatives, that is the husband, may be angry. So in such cases, we need to know how to communicate with the family, manage their distress, next of kin discussions, and cultural sensitivity. So we'll be going from the different strategies that we need to use related to communication. And we can see that most of the tasks is we need to follow this flow chart. That is, we need to initiate the session, gather information, that is information gathering, examination, explanation, and discussion of the treatment plan, and then closing the session. The next two slides will also be discussing about this in detail, and it would be just like reinforcement of what is important. So we'll have to first initiate the session, confirm the identity, and build a rapport with her. You can tell, hi, how are you doing? Depending upon the task. If it is a patient is distressed, don't go and ask them, how are you doing? We can start with, I can see that these are the things, and we are here. In that way, we can go. And then ask them the concerns. So ideas, concerns, and expectations. This has already been covered in the information gathering session. and then go for the background history, all the relevant histories. You can go through the information gathering session to see what are the relevant histories that need to be taken in each of the modules. And again, physical examination, we need to ask her that I will examine so and so, what are the things that you'll be examining, and in the presence of a chaperone. So, and only when it is relevant, examination has to be done. Next, we'll go with the explanation and planning. So we'll always, if it's a discussion of the reports or discussion of a disease, ask the patient, check her understanding, what is her previous knowledge, her background knowledge about it. And from there, you can take forward the discussion. Otherwise, we may be losing a lot of time in explaining what the patient already knows, because sometimes the role players, they will not tell us what they already know. You keep explaining everything, and at the end they'll be like, I know all this, why are you telling me all this? So always ask them what they want to know, get a confirmation, and then go from there. And again, you explain the diagnosis, and then when you go to the management, tell them these are the options. We are going to discuss about this. Shall we proceed? So in that way, you can make sure that you do not waste your time. And at the end, shared decision making, which we had already discussed. And the last 1 minute would be to go for summarizing, like what option the patient has opted for, and safety netting. So safety netting is nothing but making sure that the patient has a emergency contact number, and she has the PIL and all that. And then confirm understanding and the next steps. Next steps would be meeting an arrangement for a consultation with the consultant, or any MDT or any tests, all that we can tell and finish the session. So this is the same thing. This is in the form of a flow chart. Here again, RAPO, agenda setting, then gathering information. Again, you can see that it is a patient's perspective. What is the patient's perspective? Asking social and emotional concerns. That is, what is her mental health, the support at home, all that becomes very important. Then explanation and planning. What are the findings, options, and then close the session. The same thing that we have discussed earlier. So during this 10 minutes, you'll have to build a relationship with the patient, put in wherever empathy is needed, put it there, and always listen to the patient. Don't, cut the patient and go finish your agenda. That is, whatever you wanted to talk, don't do that. Give the patient time to talk, because these role players are very well trained and they know what to ask. Only the questions that they ask are the ones that are marked during the exam. And then provide the structure. So you should always have a structure in mind. However, the role player takes you, whichever way it takes, the role player takes you, always make sure you complete all your points. So the same thing, how to, finish your task within the 10 minutes. So the first 0 minutes, that is the first 2 minutes you read, then you'll have to put in your mind, like what are the questions I'll be asking, what are the options, and what kind of a patient I'll be seeing, whether it's an angry patient, distressed patient, or a sad patient, or the patient is really happy when the pregnancy is positive. So according to that, we can assess what kind of a patient will be coming within the first 2 minutes. And then you go into the station, the first minute you introduce this patient, confirm the patient identity, and the next 2 minutes you'll go for ideas, concerns, expectations, and ask open questions. Next, within first 5 minutes, you'll have to that is here 2 minutes, in the sense 3 minutes are over by the time you finish the information gathering. Then the next 2 minutes, that is up to 5 minutes, then you'll be giving her what is the diagnosis, and respond to her emotions. Then the next 3 minutes, you will be discussing about the options and what are the treatment plan that would be needed for her, and give her the shared decision making option. And at the end, the last 1 minute is the safety netting. Always make sure you complete the task within the 9 minutes, so that the remaining 1 minute will be there for any any questions that the role player had to ask, or something that is missed. You can always cover within the 1 minute. So always, what are the do's? Maintain eye contact with the patient. Very important. This is very important in a communication domain. And whenever you're telling the bad news, then give a pause. That will be discussing in the breaking bad news session. Then summarize, and whatever are the questions that are asked in the task, that is in the first 2 minutes, make sure all of them are completed. And what are the don'ts? Don't ever go to, go to give the information before asking for the patient's concerns. No, never use a jargon, and never ignore the patient's emotions, and never look at the clock. So then again, the empathy, this is something the nurse model, they have given a name to it. So you don't have to like follow all of it, just have it in your mind. I can when the patient comes with some difficult news, you can tell that I can see this is difficult news, or I can just see that this is really a lot to take in, or you have handled this so well. Depending upon the situation, you can use these terms. We will be here to support you. What is worrying you most? You don't have to use all of them. You can use whatever is needed according to the task. Just have these terms, that is these words in mind, so that you can use it wherever it's necessary. And here again, it's just a repetition of what we have already discussed, because communication is very important. It's important that so I'm just reinforcing the points to you. So introduce, check patient's name and understanding, and open then closed questions. For example, the patient is having heavy bleeding, then ask her, tell me more about your bleeding. That's it. The patient will tell you everything, like it's been there for the past 3 months, and I've been changing so many cloths, so many pads, so much of cloths, and all that. Then if you need to know more about some other important points, then you can ask any intermenstrual bleeding, any postcoital bleeding, or you can ask, you need to rule out anemia, any dizziness, any breathlessness. So those are the closed questions. And again, explore ICE. Never skip this in any SPT, that is the simulated patient task. And when it's a structured discussion, when you're taking the information gathering that is you're explaining to the examiner, always tell, I will explore the patient's concerns. And always avoid medical jargon, nurse model. And informed consent, we'll be discussing it now, how this has to be taken. And always offer a PIL wherever it is relevant, and the follow-up whenever it is needed. And coming to the communication with the relatives. Here, what are the key principles when we deal with the relatives and next of kin? So always make sure confidentiality is maintained. That is, you take consent from the patient before explaining anything with the relatives. So even if it is the patient's wife, that is a wife and husband, the task, it will be written that the consent has already been taken from the patient to explain what has happened to the patient to the husband. Only in such cases, you need to make sure that you can talk to their relatives. So, and the next one is always address the empathy. When they are angry, just give them some time to vent out their anger. The patient will be like, what is this? What is happening? Are you even competent to, give this treatment to the patient? My wife is suffering a lot, all that. Just be silent, listen to them. And once they finish their dialogue, then you can be like, I'm so sorry you're going through this. And then you can explain what has happened. You don't have to tell sorry a lot of times, just once is enough. And even if they still they keep on screaming, or they're angry, maybe you can tell them again, not more than once or twice, because it's already there in their script. Sometimes in the exam, how much ever times you address their empathy or concerns, they will again come back to the same thing. In such instances, it has happened recently as well. In such instances, just make sure that in the middle, you just complete all your whatever you need to ask. That you can ask, and the patient will definitely answer all your questions, and then again they'll go back and cry or be angry. So you need to mold according to the situation. And then information giving. So this would always be something that some kind of an unfortunate situation. So always be honest. Just tell them what had happened, even though they're angry, even though they just keep shouting at you. Be honest, because that is what is assessed. They do not assess what the role player is telling. They assess how you react to it. If you also get angry, and it's natural to get angry, but we have to control all our emotions and be calm with the patient. So what is important, we need to practice this kind of stations with a proper role player. Only then you'll be able to do it in the exam in the best way. So always use a simple language, no jargons, and written information and follow-up. Cultural sensitivity, always be aware of their cultural religious preferences, and do not assume. And according to their preferences, give their options. Then in all the stations, you must tell, I will document whatever we have discussed. That is very important when it comes to communication with colleagues and communication, and also patient safety as well. So, what are the difficult conversations, which I have already told you, any complaints, unexpected outcomes, or deaths? So, all that are the difficult situations. So, now we come to the breaking bad news, that is the spikes protocol. So, what does the spikes mean? Setting, perception, invitation, knowledge, empathy, and strategy. So the setting and all setting would always be there in the task. So you need not bother about that when you go into the task. Can see that there are some tissues available. So if it comes as some any discussion session or discussion with discussing with your colleagues or something, at that time you need to know all this. So setting is private. It has to be private, comfortable, sit down, tissues, then maintain eye contact and turn off all the phones and beepers. And next is perception. So this is not how you need to take the task. These are the points that you need to cover in a breaking bad news station. So perception, you must always ask the patient what the patient already knows about. So sometimes if it is a cancer patient, the patient would have already known that it is cancer, and she has come here to know what are the options available. At that time, you do not need to follow this entire spikes protocol. You can just offer the support. But when the patient does not know, then you need to ask the patient whether only then you will be able to address the patient well. So, and then invitation, then ask her, shall I explain to you about the results? Then the patient will be like, yeah, okay. And then so next, you'll have to offer support. Would you like to have someone with you, because I have a lot of information? Or if it is bad news, then you can tell them that I do not have good news for you. And then the patient would be like, would become very anxious. She would be like, what is it? What is it? And at that time, do not drag. Just give the diagnosis. So giving the warning shot is, what is the warning shot? Providing support to the patient, telling her that this is not a good news. And then give them the warning shot. I'm so sorry to say that this is cancer. And then give a pause. Because the patient will cry or do something, whatever they do, just give a pause. So that comes under empathy. That is, you are responding to their emotions, and then tell them, would you like to have some tissues? I'm so sorry that I'm so sorry this has happened to you, and I hope I do not want to be the bearer of this news, and give some just a small break, and then again go back. Would you like me to explain the options available, or would you like to come back at another time? At that time, the patient would be like, it's okay, just explain. And then give them the entire plan, options, whatever is available. For example, if it is cancer patient, what are the treatments available? And any fertility preservation, explain to them all the options. And then again, safety netting, PIL, follow-up, everything has to be covered. And next is the consent and mental capacity. So you need to take an informed consent from the patient. So always when taking an informed consent, you have to assess the mental capacity. You do not have to go and tell the patient, I'm assessing your mental capacity. You can just explain to them that this is so and so surgery that you're going to that is going to take place, and this is the reason why we are going to do this. Then you can ask the patient to explain. Can you tell me in your own words what is the kind of surgery that is going to happen? Then the patient will tell you. So in that way, the examiner will know that, okay, she has assessed the mental capacity of the patient. And you can see that capacity is always decision and time specific, and assume capacity unless there is evidence to doubt it, and document everything. Okay, so you have assessed the capacity, and then go to the benefit risk alternatives and doing nothing. That is BRAN model. Explain everything. And also there is um, okay, yeah. And then always explain to the patient that he or she has to give the consent without any coercion. That is, they're voluntarily giving the consent. And always the consent, it has to be patient specific. It has to be filled according to that situation. What are the risk factors? All the points has to be filled. And always tell the patient you can withdraw it at any time, even on the day of surgery. And so what are the mental capacity? What is the 4 parts that needs to be assessed? Understand, retain it, and weight up, that is apply it, and then ability to apply and take the decision, and communicate back the decision. These are the 4 steps. This all this need not be explained to the patient or to anyone. You just need to know. And so coming to the various communication scenarios that is, that is assessed in the Part 3 exam, and these are quite difficult scenarios. The angry or distressed patient we'll be doing all this in our courses, like how to approach the different kinds of communication stations. So as I already told you, let them vent, do not interrupt, and address emotions, identify their concerns, remain calm. Being calm is very important in this kind of stations. Even the first 5 minutes, they'll be angry. You should not waste your time by, interrupting them or not addressing their concerns. And the next is capacity and refusal, assessing the capacity when the patient is refusing. That is, the patient needs to have a blood transfusion or a life saving condition, but the patient is refusing. Then, in such cases, these communication strategies become very important, and it has to be documented and explained to the patient. All the pros and cons, everything has to be done. These are mostly negotiation stations, and if you explain to them properly, the patient will, they will accept the procedure. And then again, unexpected outcome, always be honest, tell patient what had happened, only apologize, do not blame your colleagues, and you can just tell them, I'm so sorry this has happened to you. But you should, if the patient tells that this is it because of the trainee or something, this cannot be, I cannot, I cannot specifically tell anything like that. Something like that you can tell them. And we should also explain the next steps and the support. Then any complaints, the patient would be like, I want to complain, explain to the PALs and all. You can always tell them that we'll be doing a detailed incident reporting. And once, even after that, if you would like to give a complaint, then I'll put you in touch with the PALs. Always, if the patient asks for complaining, only then you talk about the PALs. Otherwise, do not address about it by yourself. And the cultural language barriers, such as the Jehovah's Witness who do not want any blood transfusion. This is the most commonly used cultural scenarios. And again, this is the structured discussions, that is teaching the colleagues, bullying. These things come into these things become important. You should never, tell them that I will be able to, you just need to support them. You do not tell them that I will help. You not have to tell them that I will come with you. All that, don't tell them. You can also put them in touch with the trust or GMC channels as well. Just support them. So what are the common communication stations? So obstetrics and gynecology. It is counseling, that is any fetal anomaly counseling, diabetes counseling. It can be a preconceptional or a pregnancy counseling. You should explain to them about the congenital malformation risk as well, preeclampsia risk, postpartum hemorrhage, debriefing, and any stillbirth discussion. This becomes, this is very commonly asked. And again, here, cancer diagnosis, miscarriage, hysterectomy, consent, fertility counseling. And here, so as we have discussed, relatives, unexpected theater outcome, any family concerns about intrapartum care, informing partner of the diagnosis. This can come in the infertility station. And colleagues giving a handover, you use the S-bar. And referral to oncology team, that is the MDT teaching, can come in the communication with colleagues. And in conflict with midwife or nurse, raising concerns about colleagues' practice. So now we come to the various scenarios. We'll be discussing around 7 scenarios today. So we shall start over. So the first scenario is the breaking bad news scenario. This is a very important communication task. So let us go through this task. We'll be discussing only the important points that are covered. This is not a task discussion. So in an outpatient clinic, this patient, you can see that this is a cervical cancer patient, and she is a G0. Okay. So you can see she is a nulliparous, and this is a 1B1 cervical cancer. So you need to break the news and then discuss the next steps. So what are the 2 communication challenges? What are the things that is running in her mind? That is managing the shock about cancer, and then her fertility concerns, 34-year-old, age, her parity, fertility preservation. So these are the topics, that is, these are the points that you need to cover in this station. So always start with the spikes protocol and then give them the warning shot. Never, we have already discussed this. And then chunk, always give the information in chunks and then check the understanding. Never use a jargon. First, you'll be giving the pause, and then you can then explain to them the biopsy or the tissue test, the microscopy test. It has shown that there are some cancer cells in the neck of the womb. Then give them a pause. Then address their concerns, their emotions, give them support, give them an option to come back again. And then I'd give the agenda. Then explain to them, would you like me to give you the options? So you'll be discussing with them about the treatment options, and then again discuss her options about her fertility, and then give her the support. Important points that needs to be covered in a breaking bad news station. So now we'll be going to the next station. Mm. So the next station is the angry patient. So here we can see that this is a gynec ward or a post-operative clinic. And this is a 42-year-old woman. She has TLH, and then there was a minor bladder injury. And this had been recognized and repaired intraoperatively. Okay, she's having a catheter for 14 days, and she feels the surgery was botched. Okay, so whatever that is. And so now we have an angry patient. So angry patient, what should we do? Always give them time to vent their anger. So diffuse their anger. Once, let them talk, let them diffuse their anger, and then give them a sorry. And then go to explaining the complications. Always when you're explaining the complications, don't tell them this was a mistake, this was a recognized complication, and then tell them there was an MDT, and because of all this, we were able to recognize it immediately and repair it. In that way, you should make sure that something has happened, but we did make sure that we were able to treat it completely. Only thing is, you need to be with a catheter for 14 days. We are so sorry for this unfortunate situation. I can only see how difficult it must be, but this is important for your complete recovery. So in that way, you are telling them whatever has happened in a non-judgment, that is in a non-blaming manner, and at the same time you're giving them a reassurance that this can be managed. If done properly, you can always have a normal life after that. So what is the strategy? So acknowledge and validate, diffuse the anger, and then you're angry, upset. Address their concern, and then duty of candor, be transparent. And so because of the scar tissue, whatever it is, the previous surgeries and all that, and a small tear has occurred. It was repaired safely. Then to let it heal completely, the bladder needs to rest, which is why the catheter is essential. Okay. So again, safety netting. See here, you can see it was a recognized complication. Do not tell it's a mistake. Then tell them sorry for the extra recovery step. So we'll see you back in 2 weeks, follow up. Then, give them reassurance, and you can also put them in touch with counselors as well. So we'll go to the next scenario. So what is this next scenario? This is the negotiation station. Here we have a patient, a pregnant lady with a, with a large for gestational age baby, where we need to discuss about the induction. But here the patient wants a natural uninduced vaginal birth. So we are having a patient who wants a natural delivery, but you have to negotiate them to have a induction of labor. But what is important here is that you should not make sure that you should not tell the patient that this is the ideal method, this is what we have to do. Just give them the options, that is natural birth, induction, or um, the option of cesarean. Give them all the options, give them the pros and cons, let the patient decide. Okay. So communication challenges, since whatever I have explained to you, avoid paternalism, do not force an induction. Respect her autonomy. Risk communication. This is what giving the options means. Absolute versus relative risk of shoulder dystocia without using terrifying scare tactics. It can lead to the death of your baby. This should not be used as a tactic. You should give them all the options, that is all the cons, and at the end you should tell that, I'm so sorry, it can also lead to death of the baby. I'm not trying to scare you. I'm just telling you what all the possibilities. Okay. And also you can also tell there is a small risk of the baby, dying inside the womb as well. Okay. So what is important here? Why she wants a natural birth? Always in a negotiation station, always ask for why she wants it. In that way, she may be like, I do not want these, a lot of medications. I will not be able to walk. There'll be, a lot of interventions will be done. It'll lead to cesarean. Someone would have told her all this. So you'll be able to know what are her concerns, why she wants a natural birth. So you can just address each one of them. If she's like a lot of medications, we'll make sure that as less as possible we'll be using, and we'll make sure that you can be mobile as much as possible. We can have breaks to make sure you're mobile, and interventions also. Even only after taking your consent, we'll make sure maximum we will not be using any interventions, and only if needed it will be taking for a cesarean. So in that way, we can address her concerns, and at the same time, you're also telling her that whatever concerns she has, this will be taken into account. So visuals and analogies for the risk. The risk is, instead of telling risk is high, just quantify them. Quantifying it will the patient will be able to easily understand, such as 1 in 10 or 1 in 20. So in that way, or you can also tell common, uncommon if you do not remember. Not always you need to remember everything. So here, benefit, risk, alternatives, doing nothing should be explained about when it comes to a consent station, negotiation station, all this. Giving the options, you need to tell about this. And so waiting for natural labor, the benefit is you get the birth experience you want. The risk of the baby keeps growing. Shoulders getting stuck. Then if we induce, the risk is lower. And so what are your thoughts on balancing these options? Always give this. Yeah. So we were with the negotiation station. So we will be discussing about the balancing the options and giving them all the options, and give the patient time to decide. Sometimes the patient can also come and ask you, can I take some more time? I need to discuss with the partner and all that. In that cases, you should tell them that, okay, you can discuss with your partner, but do not take much time, because we need to plan for the delivery as well. Okay. And so the next scenario, this is the fourth scenario. Here we have the sensitive history taking scenario. So here it could be any domestic violence, sexual abuse, or any incontinence, painful sex, vaginismus, or there can also be sometimes, okay, so these are most of the common stations. So here we have a 55-year-old woman. Okay, so she's 55 years old, must be postmenopausal. So it's a severe pelvic organ prolapse. So whenever we see the history, always think about what could be the possibilities. Pelvic organ prolapse. So here there is a history notes, there is a hint that she's experiencing severe pain during sex, and there is incontinence during intercourse. But she's very embarrassed to discuss this with her GP. So we have a very sensitive patient. She's very anxious, and she does not want to reveal this history unless we make sure that she's in a safe place, and she can discuss with us, and we will not be judgmental about her. So in that way, we have to start the session, And you should also lower your tone and make sure you're concerned. All this becomes very important in these kind of tasks. So yeah, so you're creating a safe place, and then you need to signposting. These are important communication challenges. Normalize the symptoms. Okay, tell her that, here you can see that normalizing, remove the isolation she might feel, and then signpost her. Always ask her. There'll be some sensitive information that I'll be asking. Is that okay for you? Are you comfortable with it? And then patient will be like, okay. So she will, in somehow she'll know that there are certain questions that are going to be asked, and she might even hope that you'll ask these questions. So I'm telling you, like, not for a role player. When it comes to a patient, generally, when you're having an outpatient, your own outpatient, and you have a patient, and you are suspecting all this, then if you give her these warning shots, then they'll feel more safe and more comfortable to discuss with you anything. It's the same thing. This kind of strategies help you a lot in your practice as well. If it is molded according to the Indian scenario, we cannot use all these strategies for an Indian scenario. You need to mold it as well. So yeah, what is the strategy? Signpost to her. Yeah, see here. So I'm going to ask you a few questions. It could be related to your intimate life as well. Is that okay for you? Then normalize this condition. You should tell her that people having this degree of prolapse, they can have some leaking of urine when they cough, laugh, or even during intimate moments. Is there anything like that with you as well? So the patient would be like, oh, having this, these kind of symptoms are, recognize that it can happen when we have a prolapse as well. In that, so they will feel more safe, and then they will open up and talk to you. So give empathy, then verbal and non-verbal cues. If she hesitates, then again, you can take a few histories and then come back to it again. So this isn't easy to talk about, very common issues. Then there are treatments also available. So when you tell that there are treatments available, even a hesitant patient will open up and talk to you. So in this kind of communication stations, maintaining an eye contact is very, very important. Make sure that you maintain eye contact with all simulated patient task stations. So from the starting, I'm so and so. I'm here to talk to you in this place. In this place, always start with an eye contact. Make this like this is how you need to do the task. That's it. Not for a communication station. Any station, even if it is a maternal medicine station, mostly you won't be having any sensitive histories. But you can always do this, maintaining eye contact. So these are some important points, like avoid medical jargon. Laparoscopy, you can put it like keyhole surgery, nulliparous, first pregnancy, adenocarcinoma. What is knowing about the type of cancer? Don't tell adenocarcinoma. Incontinence is bladder leaks. Never use jargon. So the next scenario, emergency debriefing. That is, some emergency has happened, and then you are after that everything has been settled, and then you're going back to the patient and explaining this to them what had happened, because everything would be like like surprising for the patient. Everyone will be running over. Something is happening. They will be in a big trauma situation. They wouldn't know what is happening. So it is important that we go back to the patient and explain to them. This is, not very commonly done by us. But if we do incorporate all this, this will improve, increase the confidence, the patient, that is the trust the patient has in us. So the patient has delivered. This is in a postnatal ward. So this is a first delivery. She had an emergency CS, and it was a fetal bradycardia. So if it was a fetal bradycardia, we can just imagine how people would be running here and there, and the patient would have been pushed into the operation theater, and all that would have happened. So both of them are deeply traumatized, how fast and chaotic it had been. So we need to go and debrief them. So what are the things that would be running in their mind? This trauma, and then why this emergency happened. So these are the things that we need to address. So acknowledge their fear, then without sounding defensive. Don't tell them what we had done something great and all that. Okay, how do we do that? And then explain why this happened. Why the baby had a bradycardia. Why the baby was rushed to the theater. I'm so sorry, something happened. Okay. So how do you do this? Validate this trauma, like acknowledge their feelings. I can only imagine how terrifying it was. So first, address their concerns, and then it must have been chaotic and frightening. So why this happened? When the baby's heart monitor, it had the rate had dropped and it was low. So every second counts because the baby cannot get effective enough oxygen. So we had to move immediately, and we did not have time to explain the things to you, because in a category 1 cesarean section, it is just a verbal consent. No need to take a written consent. And check for understanding. Then explain to them why all this happened, according to the risk factors. Explain all this happened, then what was the importance for this fast treatment, and then ask them any other doubts, any other concerns. Then if there's anything, they will ask you, and they will ask about future pregnancy, what are all that. If it is a recurring risk, you can tell them. If not, you can tell them it might not recur. And then closure, and discuss with them about the recovery and the follow-up and whatever it is required. Okay. Okay. So we'll go to the next scenario. This would be conflicting views or refusal of treatment. So most of the time, the social and religious issues would be with the Jehovah's Witness. So in Jehovah's Witness, there are a few points that needs to be covered, and it's all given here. So I'll be discussing with you. Make sure that all these points are covered in a Jehovah's Witness. It can be either just a Jehovah's Witness and we have to explain all this, or it can also be a clubbed task, a Jehovah's Witness, along with explaining to them the treatment options. So this you need to explain, start with Jehovah's, tell them the risks and what are all that, and then go to the treatment options. In that way, you can make sure what are the patient's concerns, and according to them, you can tell the options. So the patient has signed an advance directive. She refused the transfusion of primary blood components, both the WBCs, RBCs, and platelets, plasma, even if her life is in danger. You can see that this is a 39 weeks pregnant woman. So there are 2 lives that is in danger. So always start with whatever your wishes, this will be respected. And Also, we need to ask them what are the products she will accept. For example, cell salvage or any clotting factors. All this has to be asked her. These are important points. Respect her autonomy and what are the products that she'll be taking. Then, non-judgmental attitude. Then respect her beliefs. She has the right to take her decisions, and it is also a right to keep you as safe as possible. And then explain the different fractions. That is, explain what a cell salvage is. That is, you can tell her like, would you like to take your own blood after purifying it, or some products like albumin or clotting factors. These are not related to blood. So ask her whether she will accept it. If yes, then document, very important. Document. If she's going to be taken for a surgery, then you should tell that I will inform the anesthetist or the surgeon or the team as well. And then reassure the patient. So we will document very clearly and tell labor what team will be debriefed. And our absolute priority is to prevent blood loss as much as possible. Okay. So important points in a Jehovah's Witness: respect her autonomy, ask her what she will accept, then documentation, and always use a non-judgmental attitude, and make sure that team is debriefed, that is informed about. This is a very important point that many people will miss. Okay, so the last scenario is the competency and confidentiality. We have a teenager who wants contraception. Okay, so this is a 15-year-old girl. She has come. She knows what are the contraceptive options, and she's asking for an implant. Okay, and she does not want to tell her parents because they're very strict and religious. So what are the points we'll be covering? Always make in a 15-year-old girl, when she's coming for a contraceptive, we should assess her competence. So ask her whether she's able to understand. Tell her to explain in her own words what we have explained. In that way, you can assess her understanding and decision-making capacity. So you can make sure she's competent, and then tell her that this will be, whatever we discuss here will be confidential. This will not be discussed with anyone unless your consent is given. But at the same time, you have to encourage her to involve her parents, because parents always think what is best for you. So it is always important to discuss with your family or parents whatever decisions you take. So here the same thing, confidentiality. I won't tell your parents or anyone else unless any you or anyone else is in danger. And here again, you need to make sure there is you rule out any sexual abuse. So you should tell her that, ask her what is the age of the partner, and where is she living, any social circumstances, and also you should rule out any drug abuse here, and whether she's been forced into this sexual things. So these are the points that needs to be covered in this station. Here I explain. We have explained only about the competency and confidentiality, but we should also rule out any sexual abuse and any other social circumstances. So we have come to the end of our scenarios. So let us discuss about a quick summary of what are the important communication points. So always use simple language, avoid jargon, and any task, even if it is an SPT, explore eyes. If it is an ST, tell that I will explore the patient's concerns, and then show empathy, acknowledge the patient's emotions. Okay. So here, everywhere you're making sure that patient's emotions are taken into account. So what should you avoid? Never ignore the patient's agenda. Uh, using medical jargon. Even if you use a jargon, you should always explain immediately what it means. And poor handover. That is, you're not using the SBAR structure, and you're not escalating urgent issues. That is involving the MDT, or transferring her to an ICU, such things. And so what is the important points that we need to take into account while related to the communication domain? Introduce yourself, establish rapport, how are you, all that, and then ICE, then communicate systematically, set an agenda, information gathering, then diagnosis, options, and then summarize. So always in the when you're explaining, confirm understanding, give the info in chunks, confirm understanding, and it should be in a avoiding medical jargon. And at the end, document. Always tell, I will document, I will document. This should be an important point, that you like how you introduce yourself everywhere. At the end, you should tell, I will document. Okay. And summarizing, most if you have time, most of the stations, if you cover it properly using all the points, then you can have time for summarizing. Even if you do not summarize, it's okay, but not documenting is not okay. So bad news, spikes protocol, never rush to the emotional step. Okay. Go by the steps always in bad news. Even in breaking bad news, there are various short BB and then long BB, and all that we'll be discussing about that. Then confirm the capacity before consent. So we have seen that documented. Then again, confidentiality wherever it is important, relatives when it comes to relatives, and sensitive issues, teenagers. Then duty of candor. Anything unfortunate situations, always be open, honest, and apologize. Don't over apologize also. So we have come to the end of the session. So these are some small points that I've taken from the internet related to communication. So who is a good communicator? Someone who is flexible and able to interpret other people's needs is what characterizes a good communicator. Okay. Keep all these points in mind. Flexibility, ability to interpret, and great communication skills is paying value to others. Value to, that is their emotions, their social beliefs, cultural beliefs. That is what makes you a great communicator. And communication works for those who work at it. So practice, practice, and practice. Okay. And we have come to the end of this session. So I shall, any doubts anyone would like to ask anything? Hello, dears. I can see a thumbs up. Thank you. So, can we, have an intro about all of you? Hello, Dr. Shruti.
Hello.
Hi, dear. So, can you tell us more about you?
So I'm preparing for November now,
Okay.
and I've not joined any course yet. But yes, because of your free sessions, I was interested, so I'm just looking.
Mhm. Okay. So this is your first attempt, is it?
No, no, I've attempted before, but I couldn't clear.
Okay. Okay. So you have an idea about this exam.
Mhm. Yeah, little bit. Yeah.
So we'll be having more sessions and we'll be discussing something called MCQs and recalls discussion as well. Just be online and follow our activities. How was the session?
It was really good.
Okay. So
It
anything
was really nice. Yeah.
you would it could have been improved something?
No, no, I think taking a single class on communication, this is the first time I'm attending a single class like focused totally on communication. So it was really nice.
Okay. I'm happy that it helped you. Okay.
Thank you.
Thank you, Shruti. Hello, Dr. Bhumika. Would you like to tell us about you? Hello. Okay. I think she's not available. You can also message if you want, Dr. Bhumika.
I wanted to ask you, so you'll be holding these classes on Saturday, every Saturday?
It's every Friday and Saturday. Um, Actually, yesterday
All
we
right.
had some issues with the some technical issues, so we could not continue.
Mm-hmm.
So that is the reason we are having it on a Sunday. Otherwise, we never have it on Sundays. Is
Okay,
there
okay.
anything like any preferences for you? Uh,
No, so because you were discussing, now you'll be discussing modules, I believe.
Yeah, we'll be doing from now on, we'll be doing recalls from each module. Maybe we are planning for one task per session. So we'll be having
Okay.
14 sessions. If possible, we'll also discuss about, how to go about each module, and then we'll discuss one task. And
Mm-hmm.
also we'll be encouraging some volunteers for each week as well. We'll put
All
up
right.
in the group next week. So
Okay.
yeah,
All right. Okay, okay. Okay.
okay. So thank you, dear.
Thank you. Thank you so much for your time.
Yeah. So I'll stop recording.